Our next speaker, guys, can we please? Okay, over here. Can we please sit down, please? Thank you. Okay. Okay. So our next speaker is a personal favorite of mine. So Dr. Devi Shetty is a cardiac surgeon and entrepreneur who's the founder and chairman of Narayana Health, a chain of 47 healthcare facilities in India and abroad around Asia. As one of the world's foremost innovators in healthcare delivery, Dr. Shetty has taken one of the most widely performed surgeries in the world, cardiac surgery, and has driven its cost down from $100,000 to just under $2,000. A champion of low-cost care delivery, Dr. Shetty has transformed the healthcare landscape in India using a robust process innovation and has bold visions for what healthcare should look like around the world. And with no further ado, I'll welcome all the way from Bangalore, India, a man who's woken up very early to come speak with us here at Stanford, Dr. Devi Shetty, please. Thank you.
Thank you so much. Thank you.
Okay, Dr. Shetty, can you hear us?
Yes, I can hear you. Can
Perfect.
you hear me?
Yes, we can. Yes, he can see us. He can see us on the thing. Okay.
Sure.
All right, so let's go ahead and get started. I want to make sure. I want to make sure to leave time for student questions because a lot of people have approached me. Do I have a chance to say hi to Dr. Shetty? So I want to get through my questions as soon as possible. Okay, so let's start with motivation, right? So you trained as a heart surgeon in both India and the United Kingdom. I work in cardiovascular medicine, so I'm around a lot of cardiologists, and I see that it's one of the most arduous and most difficult specialties, even within medicine. So I guess my question to you is, what prompted you to say, I need to go beyond the clinic? It's not enough to just do surgery. I need to go to, systems level thinking. I need to go outside of the operating room to really improve care on a wide scale. What prompted you to leave the OR?
Thanks. Global healthcare and wellness industry is over $12 trillion industry. It's the largest industry in the world. Unfortunately, after spending $12 trillion, less than 20% of the world's population access to safe, affordable healthcare. Something is fundamentally wrong with the way we are delivering healthcare. And I believe that India will become the first country in the world to dissociate healthcare from wealth. India will prove to the world that the wealth of the nation or the wealth of the family has nothing to do with the quality of healthcare its citizens will enjoy. And within the next 5 to 7 years, why I am confident of this thing happening? This is because, unlike most other industries, health sector is not limited by any finite components. Healthcare is delivered by people, and people are infinite. When I retire or when I die, somebody else much smarter than me, much better than me is going to replace me. So the transformation in India will happen mainly because of the current policies of the government, wherein we have virtually doubled the number of medical schools from 50,000, 60,000 undergraduation seats to 110,000 in less than 7 years. So the many things what we have done, and also, as you know, India is a pharmacy of the world. We have all the jigsaw puzzle pieces, and someone has to put it together. And this amazing transformation will be here if you start addressing the fundamental problem of Indian healthcare.
Perfect. So one question I have is on this question of labor. So we hear a lot about India having such a young working population, right? The median age is 28, and the population is just growing, and the younger part of the population is also growing. So I mean, I would guess that that's a positive for India's healthcare industry. But sort of what trends do you see? What trends are you excited about in terms of how India is training healthcare workers? Here in the United States, I plan to go to medical school myself. And we're always told there's not enough doctors in the U.S. or it takes very long to train doctors in the U.S. India has a very different model of training physicians. So so what sort of trends are you excited about in how India is training healthcare professionals, not just doctors, but also nurses, surgeons, whoever? What is changing in the way that India is looking at training people, as that's the most fundamental component of healthcare, as you say?
I'll give a simple example. A heart surgeon who practiced for 30 or 40 years in US, in his entire professional life, he would have done about 3,000 or maybe 4,000 heart surgeries. We in India have heart surgeons who have done more than 3,000 surgeries, and they're only in their 30s and early 40s. In the US, if a heart hospital does 200 heart surgeries a year, it is recognized as a training institution to train future heart surgeons. And the hospital where I work, we do 800 heart surgeries a month. So you can just imagine the volume of exposure our young doctors are receiving. And in 60s, they're going to dramatically change everything. And also, if you really look at the training structure has to change. You have talked about the nurses. I'll give you an example. A nursing student spends 4 years in a nursing college. Then she comes to the ICU to work or a ward. It is the first time she's getting exposed to that complex machines and all the intricate gadgets every. This is after 4 years of training. They are just beginning to learn. You look at the pilot training institution. A girl or a boy at the age of 16 or 17, they join the pilot training institution. They undergo training for 10 months. At the end of 10 months, they are certified to fly a plane with the passengers in it. There is something structurally wrong with the way we train doctors and.
Do you think that that's
Someone to.
Oh, sorry to cut you off, but just one quick point on that. When you say that, there's something fundamentally wrong with the way, the structure with which healthcare professionals are trained, what would you say to people who say, it's the riskiest industry, or it's the industry where, loss of life is very easy, and that's why we need extremely long times? Would you say, are you suggesting that there's a more efficient way to do it in a shorter amount of time? And if so, could you give some examples as to what exactly those measures are? We're at Stanford. We have representation from the medical school here. I'd love for them to hear that as well.
There is many fundamental problems. When I used to work in England, I used to work for, as a young surgeon, 12 to 18 hours a day. So I could get all the skills I wanted in a short period of time. Today in England, no doctor can work. A doctor who is working in training program cannot work for more than 48 hours a week. If a heart surgeon undergoing training program works only for 48 hours a week, by the time he gets experience to be an experienced doctor, it's a time for him to retire.
Right.
There is something fundamentally wrong. And look at the nursing college or a medical college. Most of the teaching happens in the classroom and in the library. How can you teach someone to swim in a classroom? If you want to teach someone to swim in a class, get them into a swimming pool. And the best place to train the nurses and doctors are the bedside. You go through your training program, how many hours you spent as a medical student sitting at night holding the patient's hand. You have never done it. So we have to ask ourselves, are we training academic doctors or we are training practical trained doctors? Most of the things what you learn is already available in the internet, which is given by best teachers. So something has to go wrong. I mean, something has to be done. It can't go on like this.
Right. No, I think your point about practical training is very well taken. I speak to a lot of residents and medical students here at Stanford who really crave, opportunities to do that. And that sort of brings me to talking a little bit more about India in particular. In India is really interesting in that it has such a wide spectrum of need when it comes to healthcare. I mean, in some parts of the country, you still have diseases like tuberculosis, malaria, and in some parts of the country, in the big cities like Delhi or Bangalore, you're dealing with triple bypass surgeries that I'm sure that Narayana Health is very skilled at. So, I mean, how do you see India with such a wide range of with such a wide range of health problems? How do you see India as positioned as a training ground, really? And do you see it as a training ground only for Indian healthcare professionals, or what do you think that healthcare professionals outside of India could do to leverage leverage the resources that exist in India for something like training?
See, we have been training heart surgeons for NHS, some of the senior established surgeons in England, where our products. We have been training surgeons for China, for Africa, and maybe quite a few European countries. And India is open for training, fortunately. But we may not have the ability like US to give a certified degree, which is recognized in their respective country, but it's a matter of time it's going to happen. The reason why a product from India, a doctor or a nurse from India is definitely differently positioned is because, first thing, why we are bullish on health, because if you look at an American doctor or an American nurse, they will never leave America. Look at a British doctor, they will never leave England. Whereas the Indian doctor, Indian nurse is very comfortable to working in India, in England or US. So this is our greatest strength. And when you're open to understand new things, and the most of the Indian doctors like me, we got trained in India, we understand what Indian healthcare is, and then we need to go to England or US or wherever. And we understood the best things of those healthcare delivery model. We came back and we are trying to assimilate different models and trying to see what best fits our country. And today the government policies are such that we are in a hurry. We do not want changes to happen after 50 years. We want it to happen now. So the pace at which things are changing in India to dramatically change the concept of funding the healthcare. Across the world, the thinking of healthcare is that healthcare has to be funded by the government with the taxpayers' money. And even in the US, that is the same thinking. But we analyze the countries which have successfully implemented healthcare to the citizens with the taxpayers' money. There are only three things that are important with these countries. Countries which have offered healthcare to the citizens free of cost with the taxpayers' money are invariably small countries with a population of 1 million, 2 million, 5 million. No single country in the world, large country in the world, including United States of America, can offer healthcare to the citizens free of cost with the taxpayers' money. The second problem, second thing what we notice in these countries, all these countries have a very high tax to GDP ratio of 25%, 45%, 50%. And a large country like India can't afford to do that because our tax to GDP ratio is about 11.5%. And the third thing is these countries are already spending more than 10% to 18% of the GDP on healthcare. That is unsustainable by any standards. So our policy is trying to go for a universal health insurance than a universal health given by the government. And this is the way our government has reformed the insurance regulatory authority, and organization hospital like ours are given the license to become a health insurance company, which is unthinkable even 10 years ago. So these major steps which have been taken by the government will have a massive impact on the way healthcare is delivered in India. You must realize that we are 1.4 billion people. What a country people can do, we can't afford to do that.
Right. No, I think that's really interesting how you say, like, one thing that always fascinates me about India, particularly in the healthcare scene, is how you're able to get such a high variation in the number of, these funding models that can exist. In the United States, we have these sort of very well known, very defined types of insurance, for healthcare that exist. You have employer funded insurance, you have Medicare and Medicaid, and that's, those are pretty much the your options. But in India, it seems like you have the latitude, or you have the ability to try all these unique sort of funding models that can fit for 1.4 billion people at scale. So, a lot of people in the audience, are very interested in, a lot of people have done work in India. A lot of people are from India. A lot of people want to do work in India, particularly in healthcare. Can you talk a little bit about whether starting with the insurance landscape, but other things too in innovation? Can you talk about the relative advantages of working in India when it comes to healthcare innovation? There's a lot of people here at Stanford who do healthcare innovation, from medical devices to biotechnology, all the way up to this care delivery kind of innovation and policy and procedures and business models. Can you talk about why India in particular is a super interesting, or should be a super attractive place for people in the United States and from abroad to come and try to implement new business models to get care to a very wide number of people?
Let me talk about one example, what you
Sure.
just said. It's about the technology, how technology will disrupt or transform healthcare. We believe that in the next maybe 5 to 10 years' time, world's largest healthcare provider will have no beds. It will be a software with few beds attached to it. And that's going to happen. Now, if this has to happen, the software should be appealing to the doctors, nurses, technicians, whoever are using it. So with that idea, we started building the EMR, what your doctors you are using in US costs not millions, it costs billions that we can't afford. So 20 years ago, I'm just giving my example of in our own organization, we started our journey when I wanted to get one of the top Indian software companies to build a EMR for us. My son, who happens to be a graduate from Stanford Business School a few years ago, he insisted that we shouldn't do that. We should build our own software. So much against, he went ahead and did it. It's called Meda and Atma. These are the software we have. The whole idea is that technology disruption to happen, you need to have an open mind, which not many countries have. The billion-dollar EMR, what you see in your country, are built for the desktop and the laptop. Doctors look at the desktop and laptop 5 to 6 times in a day, but mobile phone 200 times in a day. But your EMR is not built for the mobile platform. So we took the route of building our electronic medical records for a mobile platform. The second thing, doctors treat the patients by chatting with all their colleagues. A cardiologist will talk to the intensivist will talk to the radiologist and nephrologist. So we built our software on a chat platform so that doctors all can interact with each other, even though they are not on the bedside. And in the process, today, I don't go to the ICU after I have done the heart surgery because I finish my rounds early morning sitting at home because I can see the patient, I can see all the data, the analytics will give me the risk score, whatever I want. I can talk to anybody I want. It's all in my mobile phone. And these technologies are going to dramatically. 80% of the hospitals across the world do not have electronic medical records. In the US, you may say that 95% of the hospitals in US have EMR and we are so advanced. Yes, 95% of the hospitals in US have EMR because your President Obama distributed $35 billion to all the hospitals to use and implement EMR without really insisting on quality or the user friendliness. So in India, we are blessed in having phenomenally talented software engineers. We have to just tell them as a doctor what my problem is. In 24 hours, they come up with the 10 different solutions for me to choose from. So amazing transformation. Like one of the criteria our software engineers told us that any EMR we develop for it shouldn't have a keyboard because doctors are not designed by God to type. So it has to be on a tap or on a voice. So these are the innovative things what they have done. And today we are willing to give this EMR to any hospital in the world if they want to use it at a price what they can afford to pay. The reason is we spend millions of dollars and 20 years to develop. And I can afford to this because this is the beauty of converting atoms into bytes. If I have 1 kilo of rice, I give you half a kilo of my rice. I lost my half a kilo. I developed the most advanced EMR, which I enjoy using it. I give it to your hospital free of cost. I still have what I have, and you can have what I have. This is the beauty of converting atoms into bytes. And this is how this world will be transformed. And this is how India will have a dominant role to play because of our ability to create digital products which can change every sector of the business.
Yeah, I mean, it seems like from what you're talking about, right? All these, I mean, it seems like the adoption of digital technologies is particularly in the healthcare space. We see it across India, with things like UPI and Aadhaar. We see the adoption of digital technologies that has just taken off, especially in the last 5 to 10 years. And from what you're describing, it seems like that trend has not excluded healthcare. What is it about India, the market, or just what is it about India that allows this adoption to happen so much quicker than in developed markets like the US or Europe?
We are an amazing country where magical things happen. We have gone from no radio to color TV with a few hundred channels in less than 30 years. We have gone from no phone to the most modern mobile phone in years. So today, we have perhaps one of the largest number of mobile, the digital, the IT, the sort of internet-enabled mobile phones in the world, and the cost of like we run hospitals in some western parts of the world, some wealthy countries, where significant number of population do not have internet in their phone because it's too expensive. Whereas in India, even the beggars have internet in their phone. So we have democratized entertainment. Today, the richest man of the country and the poorest man of the country has access to every entertainment channels. Today, the richest man or the poorest man of the country has access to the same mobile communication tool what anybody can afford. Of course, he may not have a phone, but he has a phone with which he can communicate with whoever he wants. So digitization, technology has percolated to such a low level at every level of the country that everyone is connected. Everyone knows how to get into the internet, look at the data. There are amazing stories we see in our hospital. There are 60-year-old, 70-year-old ladies who like a typical village ladies, and they come to the hospital. My heart hospital is paperless. All the reports go to their mobile phone. We don't print any paper reports. When a doctor asks his ladies, madam, I want to see your echo report, she will go to the NH Care app and she will show exactly where the application, where the echo report is. And all this transformation happened in such a short period of time. Adoption has happened in such a rapid pace, mainly because of the affordability. It could reach out to everyone.
Perfect. No, I think that makes a lot of sense. I think, even in the times that I've gone back to India, and I haven't been back to India for quite a few years, but every time one of my friends or one of my family members comes back from India, they tell me it's a completely different story every time. And more, it seems like, especially on the digital side, it seems like a place that I can only imagine, healthcare working. Sometimes it seems so seamless there. Um, you know, before as we're coming to the end, because I do want to leave time for some student questions. What is your, because you alluded to this a little bit with digitization, and fully fleshing out the EMR system, but just if I could get your summary on what is your vision for India's healthcare system in the next 25 years, right? You are at the forefront of care delivery innovation. What are the primary issues that you think need to be addressed, and where will the innovation to solve those issues come from? Will it be from engineers and doctors sitting in this room? Will it be from the ASHA workers? Will it be from, well, I'm sure it'll be from employees of Narayana Health, but outside of there, where else do you think that innovation will come from, and what are the biggest challenges that India faces in the next few decades?
As I said in the beginning, we are spending over $12 trillion across the world for healthcare. People are deprived. Today, even if you double the allotment of 12 trillion to 24 trillion dollars for healthcare, it will not reach out to even half the population. And that additional $12 trillion doesn't exist.
Right.
Now, advanced countries like US and Europe, you're trying to develop cancer drugs to cure breast cancer with billions of dollars. What we are trying to India is to detect breast cancer at an early stage, in stage 1. So with one minor surgery with the local anesthesia, we can cure the breast cancer. So if you really want to transform the healthcare, of course, it is good to have new medicines, new machines, faster scanners, but early detection is going to transform the way healthcare is delivered. For that to happen, the cost of diagnostics should go down. And that is going to happen in India very, very dramatically. Then the access to early diagnosis, all these investigation, will be taken away from the hospital. Healthy people do not want to go to the hospital.
Right.
If we create multiple diagnostic centers which offers early diagnosis in shopping malls, in tech parks, and all the convenient for the people, everyone will go for a preventive checkup once a year. When they go to see a doctor at the early stage of the disease, most disease can be cured. And if you can't give them, you can give them meaningful life. So the essentially, to reduce the cost of healthcare, give outstanding results, and make customer happy, the investment every country is preventive care and early detection. And this is the direction we are going. And also change the concept of a hospital. About 16 to 18% of the heart surgery done in India is done by us. More people develop heart attack, it is better for my business. And I have no incentive to prevent people from developing heart attack. Now we are becoming a health insurance company. When I become a health insurance company, my priorities will change. I want to make sure people do not develop heart attack so that I don't end up spending more money, I end up saving money. So when the health hospital become health insurance provider, the whole relationship between the customer, that's the patient, and the hospital will change. So these are the fundamental shifts we are trying to bring about in India, which will have a massive impact.
Perfect. Well, with that, I want to leave some time for questions. So if you have a question, please raise your hand, and someone will bring a mic right over to you. And Dr. Shetty, I'll just have them ask their question directly. You may or may not be able to see them. You might just see the stage. Yeah.
Sure. Thanks.
Hello, doctor. So my question is regarding your earlier statement regarding practice difference between US and India. To just summarize, so is what you mean is the doctors in India have way more hands-on experience as compared to doctors in the West? Is Yeah, and that's the reason why I think population also, I'm assuming, is a factor to that. And is that what the assumption was, that doctors, because of regulations in the US plus less like less population, maybe they don't have that much experience?
The reason we become Indian youngsters become doctors 2 years earlier than US doctors. So we have 2 years advantage. The second reason is the hospital where most Indian doctors get trained treat huge number of patients. So in the process, they're exposed to large number of procedures. We're all technicians. You keep on doing something, you get good at it. There is nothing unique about a genetic. We are not differently wired. We are like anybody else. But it is just that in a short period of 3 years or 4 years, our doctors, when they go through training, are exposed to a lot more hands-on training, lot more overall training, exposure to a lot more patients than a US and European hospitals. Like your restriction on the number of hours where a doctor is able to work. I'm talking, you can't have a nature. If why people are young and they gradually become old. Young people are expected to work much harder, much longer than the older people. But your regulation doesn't allow a young 27-year-old doctor to work longer than a 60-year-old doctor who's about to retire. So there is a structural problem, and also the number of patients what they can see. So we obviously have the advantage because of our the number of population and the need for the healthcare.
Okay, thank you so much. Our next question, you can go over there, Pragati.
Thank you for the talk, Dr. Shetty. I think my question is that Narayana Health is a great example of how the private sector has been able to create an affordable way for people to get tertiary healthcare access. But I feel that there is very limited private play today in the primary healthcare space. Do you see there is scope in the future for the private sector to go deeper in that space? Be it OPD insurance or even just, like you said, preventive healthcare, more focused on either rural or urban poor sectors?
We always look at the future as an extension of the past. Future is different. The entire primary care in India will get shifted mode. But today that is not possible because when a doctor sees you for the first time, he doesn't know whether you're a diabetic, hypertensive, whether you have an existing heart problem. Imagine a situation where every Indian citizen goes for a preventive checkup, which is very affordable, and they have all their medical records in their own mobile phone. And when they tap on the app, a nurse comes online. She will take the initial history, and then the doctor will come online. That is going to be the real primary care. The concept of a doctor practicing next to your place of residence with a stethoscope around his neck, who doesn't have a lab to do the blood test, who doesn't have an echo machine, who doesn't know how to do an echocardiogram or ultrasound. This was a utopian way of looking at the primary. This is one of the Victorian way of looking at the how care should be. The future primary care will shift completely digitally. It will be available online. So doctors will see the patient from wherever they are, and the patient will see the doctors online from wherever they are, irrespective of what time of the day or night is. And this is going to be the future. And it is going to happen not after 10 years, 20 years. It's going to happen in the near future.
Perfect, thank you. Next question, please. So yeah, we'll go right over here. Just give us 1 second. We're running the mic over.
Hello, Dr. Shetty. My name is Kundan. Thanks firstly for a great brief session. I have a question regarding the health insurance model that you just mentioned, that now the hospital chains themselves can become insurance providers. So like from my experience in the US, the insurance companies, like there's a lot of friction, regarding like denying claims, and so on. So, like, as a healthcare provider yourself and becoming an insurance provider, what pros and cons do you see against versus a model where there's a much bigger insurance company which provides it?
In India, we looked at all these problems, and we now have come up with a dramatically different model. Today in India, there are three. Why health insurance has not become popular in India? Let me talk from the Indian context. There are three key stakeholders in healthcare delivery. First is the health insurance company. Second is the hospital. And the third stakeholder is the patient. Health insurance company doesn't trust the hospitals. Hospitals do not trust the health insurance company. And the patient doesn't trust both the parties. So you have three important stakeholders who do not trust each other. That model cannot be scaled up in any business. If the three stakeholders don't trust each other, that business cannot be scaled up. Now look at my position as a heart surgeon. When I tell a patient that you need a bypass grafting, first thing in the patient's mind is it really required? Or this man is asking for a bypass to make some money out of me. Whereas when I become a health insurance company and I tell the patient that you need a bypass, then patient has no bypass. So the moment a hospital becomes a health insurance company, they will work very, very hard to make sure that the patient doesn't land up, because that is the only way they can save money. Then the customer and the provider of service, their interest is aligned. And when that happens, that business will blossom. And this is exactly what we are trying to do, to align the interest of the doctor, hospital, and the patient.
Perfect. Next question, please. Anyone? Okay, here it is.
So what do you expect from government of India to so that there is a positive collaboration between private sector and public sector?
In the last 7 to 10 years, we have seen massive shift in the way government is approaching towards healthcare. First is, in 7 years, we have almost doubled the medical seats in the country, nearly double the number of post-graduation seats in the country. This is unthinkable. What took 70 years, the current government has done it in less than 7 years. Because you know the conflict in medical education, the high cost. So this has been addressed. And give you another example, looking at the financing problem of healthcare, which is a health insurance company. 5 years ago or 10 years ago, I couldn't think of a hospital like mine getting a health insurance license to run health insurance. Because health insurance, as you know, is a very, very regulated body. And all they did was to insurance regulatory authority, they packed with extremely passionate people who are open to new models. So essentially, many, many things have happened. We are working with IIT Kanpur. Around 1.5 years ago, we started a project to develop left ventricular assist device, LVAD, or artificial heart. There is only 1 or 2 companies in the world making artificial hearts. And that costs in India millions of dollars our people can't afford. So within the next 1 or 2 years, we will have a indigenously made artificial heart, considered as the most complex machine to make. And our scientists, our engineers are super confident that it will happen. So essentially, there is a newfound hope and the confidence and the enthusiasm to change the rules of the game. And government is a very important partner in this changing process. We see these changes happening. It's not in words, it is in action. That is what with our current government.
Thank you.
Perfect. Well, that's unfortunately all we have time for. Dr. Shetty still has to start his day, so I don't want to take too much from his Saturday. But Dr. Shetty, thank you so much for gracing us with your presence, and we hope to welcome you in person very soon at Stanford. Let's give him a big round of applause, please. Thank you.